Management of Anorectal Abscess and Fistula in NO. A formal podcast review of the American Society of Colon and Rectal Surgeons 2022 guideline. Welcome to this formal review from the Everything Surgery podcast. In this episode, we are discussing the management of anorectal abscess and fistula in NO, based on the 2022 guidance from the American Society of Colon and Rectal Surgeons. We begin with the accepted pathophysiology. An anorectal abscess usually develops when an anal gland becomes obstructed, while a fistula in NO results from chronic infection and epithelialization of the abscess drainage tract. Anorectal abscesses are described by the anatomic space in which they develop. Ischiorectal, also called ischianal, abscesses are the most common, followed by intersphincteric, supralevator, and submucosal abscesses. These abscesses occur more often in males than females, may develop at any age, and have a peak incidence among individuals between 20 and 40 years of age. In general, treatment requires prompt incision and drainage. The diagnosis and treatment of necrotizing soft tissue infections and Fournier's gangrene are outside the scope of this discussion. A fistula in NO is an epithelialized tract that connects the perianal skin to the anal canal. Among patients with an anorectal abscess, 30% to 70% present with a concomitant fistula in ano. Of those who do not present with a fistula initially, approximately 30% to 50% will later be diagnosed with a fistula in the months to years following abscess drainage. While anorectal abscesses are categorized by anatomic space, fistula in ano is classified by its relationship to the internal and external anal sphincters. For context, the Parkes classification describes several fistula patterns. A submucosal fistula is superficial and does not involve sphincter muscle. An intersphincteric fistula crosses the internal sphincter and then travels to the perianal skin without involving the external anal sphincter. A transsphincteric fistula begins at the internal opening near the dentate line, passes through the internal and external anal sphincters, and terminates in the perianal skin or perineum. A suprasphincteric fistula courses upward into the intersphincteric space, passes over the puborectalis muscle, then descends through the iliacoccygeus muscle into the ischiorectal fossa and perianal skin. An extrasphincteric fistula travels from the perineal skin through the ischiorectal fossa and levator muscles into the rectum, remaining completely outside the external sphincter complex. Anal fistulas may also be described as simple or complex. Complex anal fistulas include transsphincteric fistulas involving more than 30% of the external sphincter, as well as suprasphincteric, extrasphincteric, horseshoe, recurrent, or branching fistulas. Fistulas associated with inflammatory bowel disease, radiation, malignancy, pre-existing fecal incontinence, or chronic diarrhea are also considered complex. Because the anterior sphincter may be attenuated in women, anterior fistulas require special consideration. Simple anal fistulas have none of these complex features and generally include intersphincteric and low transsphincteric fistulas involving less than 30% of the external sphincter. It is important to distinguish cryptoglandular disease from anorectal abscess and fistula in ano related to Crohn's disease. In Crohn's disease, fistula in ano occurs in approximately 10% to 20% of patients in population-based studies and may be reported in up to 50% of patients in longitudinal studies. In tertiary referral centers, nearly 80% of patients with Crohn's disease may have a history of fistula in ano. In this setting, anorectal abscesses and fistulas appear to arise from penetrating inflammation rather than infection of an anorectal gland, and patients are typically managed through a multidisciplinary approach. Initial evaluation of anorectal abscess and fistula in ano. In the initial evaluation, a disease-specific history and physical examination should be performed. The clinician should assess the patient's symptoms, relevant medical history, abscess or fistula location, and the presence of secondary cellulitis. This is a strong recommendation based on low-quality evidence. Routine diagnostic imaging is not typically required for every patient with anorectal abscess or fistula in ano. However, imaging may be considered when there is an occult anorectal abscess, a recurrent or complex anal fistula, immunosuppression, or anorectal Crohn's disease. This is a strong recommendation based on moderate quality evidence. Anorectal abscess. For acute anorectal abscess, prompt incision and drainage remains the central treatment. This is a strong recommendation based on low quality evidence. In selected patients with simple anal fistulas, abscess drainage may be performed together with fistulotomy. This is a weak recommendation based on moderate quality evidence. Antibiotics are generally reserved for patients whose anorectal abscess is complicated by cellulitis, systemic signs of infection, or underlying immunosuppression. This is a weak recommendation based on moderate quality evidence. Anal fistula. For a simple fistula in ano in a patient with normal anal sphincter function, lay open fistulotomy may be offered. This is a strong recommendation based on moderate quality evidence. Fistula in ano may also be treated with an endorectal advancement flap. This is a strong recommendation based on moderate quality evidence. Transsphincteric fistulas may be treated with ligation of the intersphincteric fistula tract procedure. This is a strong recommendation based on moderate quality evidence. A cutting seton may be used selectively in the management of complex cryptoglandular anal fistulas. This is a weak recommendation based on low quality evidence. The anal fistula plug and fibrin glue are considered relatively ineffective treatments for fistula in ano. This is a strong recommendation based on moderate quality evidence. Minimally invasive approaches that use endoscopic or laser closure techniques may achieve reasonable short-term healing rates, but long-term fistula healing and recurrence rates remain uncertain. This is a weak recommendation based on low-quality evidence. Anorectal fistula associated with Crohn's disease. When anorectal fistula is associated with Crohn's disease, management typically requires a combination of surgical and medical approaches. This is a strong recommendation based on moderate quality evidence. Asymptomatic fistulas in patients with Crohn's disease typically do not require surgical treatment. This is a strong recommendation based on low-quality evidence. Draining setons are useful in the multimodality therapy of fistulizing anorectal Crohn's disease and may be used for long-term disease control. This is a strong recommendation based on moderate quality evidence. Symptomatic, simple, low anal fistulas in carefully selected patients with Crohn's disease may be treated by lay open fistulotomy. This is a weak recommendation based on low-quality evidence. Endorectal advancement flaps and ligation of the intersphincteric fistula tract procedure may be used to treat fistula in ano associated with Crohn's disease. This is a strong recommendation based on moderate quality evidence. Patients with uncontrolled symptoms from complex anorectal fistulizing Crohn's disease may require fecal diversion or proctectomy. This is a strong recommendation based on low-quality evidence. Local administration of mesenchymal stem cells is considered a safe and effective treatment for selected patients with refractory anorectal fistulas in the setting of Crohn's disease. This is a weak recommendation based on moderate quality evidence. Thank you for joining us for this episode of the Everything Surgery podcast. If this discussion on anorectal abscess, fistula in ano, Crohn's disease, and surgical management has been helpful, please like the video, share it with colleagues, and subscribe to the channel for more formal, evidence-based surgical conversations. Until next time, this is the Everything Surgery podcast, where we dissect the extraordinary.